Hi everybody, welcome back. You're watching Nurse Inga, and I'm thinking that maybe I should change the name of my channel currently to like Nursing School Doesn't Have to Suck or Surviving Nursing School or something like that. But it is the end of March 2020 and our country is obviously in great turmoil as far as education goes. So moving a lot of our stuff online. And for those of you who subscribe to my channel, you're going to get bombarded with some videos here. Some of it's going to feel like a little bit of repeat of things that I've done in prior years, but just wanted to update some of the information. And honestly, while I love doing these videos, I really miss spending time in the classroom with my students. So these are for my students and for any of you listening in online. Thank you, as always, for watching, and good luck to you in all of your studies. Today we're talking about the GI system. And we're going to start with kind of upper GI disorders, then I have a separate video for lower GI disorders, but we're talking really about oral cavity problems first, and then we're going to move down into esophageal and gastric and stomach issues. So oral cavity disorders can severely impact tissue integrity. So anytime the mucous membranes are injured, it can cause infection or ulceration. When there's pain in the oral cavity, it impairs nutrition, and that can cause problems with feeding or even fluid intake. And if there are abscesses or swelling, it can actually impair gas exchange and breathing. Oral cavity disorders can also impact things like self-esteem and body image, and they can cause excruciating pain and impair speech. Oral cavity health is impacted by cognitive development, access to care, housing, hygiene products, institutionalization, so whether they are incarcerated or in a facility, tobacco and alcohol use, diet, oral cancers, and excess dietary intake, especially those that are high in carbohydrates. For maintaining good oral health, there are some best practices. You should do self-examinations of your mouth every week and report any unusual findings or any changes, eating a well-balanced diet, good oral care, so brushing and flossing, seeing the dentist twice a year to have a professional evaluation, maintain stress as much as possible, so that you use like healthy coping mechanisms, but so you're not like, grinding your teeth or bearing down or eating bad foods that contribute to poor oral health. Avoid contacts with agents that can cause inflammation of the mouth, so mouthwashes that contain alcohol or swabs that contain glycerin, but then also, drugs and chemicals, tobacco, and drinking alcohol. If possible, avoid drugs that can cause inflammation of the mouth or reduce the flow of saliva. And be aware, anytime you bite down, if you have malocclusion or changes in your bite, if you have pain, swelling, you should seek medical attention promptly. If you wear dentures, they should be in good repair and fit properly so that they don't damage or injure the gums. So some of the concerns that we have with oral cavity problems include things like stomatitis, which is inflammation of the oral cavity. And this includes lesions like leukoplakia and erythroplakia that can lead to oral cancer. And what's called sialadenitis. So this is when you get like a plugged or inflamed salivary gland. So we're going to start off talking about xerostomia, which is dry mouth, and stomatitis. And stomatitis frequently is either primary stomatitis, which is an aphthous ulcer, herpes simplex virus, or traumatic ulcers of the mouth. So the aphthous ulcers are what we refer to as canker sores. Or it could be a secondary stomatitis, and those are opportunistic infections like candidiasis. And Secondary stomatitis could also be related to things like drug use, alcohol, allergies, vitamin deficiencies, systemic disease, or any sort of irritant, including tobacco, and then like reactions to foods. So anything that causes inflammation within the oral cavity that can break down the mucosa, causing that inflammation or ulceration or erosion, is referred to as stomatitis, and that's pain. But it also, because it breaks down the mucous membrane, it creates this portal of entry, so the person is at risk for both bleeding and infection. From a nursing standpoint, our management is focused at prevention. So oral hygiene is our primary route of prevention. Collaboration with primary care, the dentist, even the ear, nose, and throat doctor if the person requires a consult with them. Avoid the use of harsh commercial mouthwashes if oral lesions are present because they can be very irritating. And use soft brushes and warm saline or sodium bicarbonate to clean the oral cavity. This is a picture of candidiasis, which is a white cheesy plaque that can bleed when it's removed. People who use antibiotics or steroids or who have diabetes are at greater risk for developing candidiasis, which is essentially an oral yeast infection. It's an overgrowth of natural flora. These are treated with antimicrobials, anti-inflammatories, immune modulators, and topical agents. We have to be really careful though when we give somebody like topical lidocaine, like a swish and spit or swish and swallow or gargle with lidocaine, because it makes them feel better, but then they're more likely to burn their mouth if they drink something that's too hot because they can't sense temperature, or they're more likely to aspirate if they choke on what they're eating or drinking. Be alert for signs and symptoms of dysphagia when people have stomatitis or other oral problems. And there's an acronym called PASS, which stands for P. Is it probable that the patient will have difficulty swallowing? A, account for previous swallowing problems. The first S is screen for signs and symptoms, and the second S is for speech language pathology referral. So if the person has signs and symptoms of dysphagia, think about, do they need a speech language pathology referral? Well-fitting dentures and other oral appliances we talked about are very important, but if you're doing an assessment, you want to remove them so that you can see the mucosa underneath, and if the skin is ulcerated or if the oral mucosa is ulcerated underneath the appliance, then you want to leave it out. In addition to that, oral hygiene should be, before and after the meals and as often as needed in between. Increasing mouth care to every 2 hours or more frequently if the stomatitis is not well controlled. Using the soft toothbrush or gauze or, the toothettes for oral care. Nothing harsh or hard or firm in the mouth. Frequent rinsing with warm saline or the sodium bicarb can help kind of buffer and take away some of that pain, and teach the patient to avoid those commercial mouthwashes and the limb growth hormone swaps, as I mentioned before. Help the patient select soft, bland, non-acidic foods, and the topical analgesics are very effective, but again, be careful with safety issues. Leukoplakia is literally just means kind of white plaques, and leukoplakia is seen in the oral cavity most often on the lips or the tongue. It's slightly raised and sharply rounded, as you can see here. These are slowly developing changes in the oral mucosa membranes that cause thickened, white, firmly attached patches that cannot be easily scraped off. So remember, with the candidiasis, we can scrape it off and it will bleed, but with the leukoplakia, you cannot scrape it off, so it stays on there. This is most often caused by things like long-term mucosal trauma, poorly fitting dentures, cheek biting, broken and sharp teeth. And then tobacco use, whether smoked or chewed, is definitely a risk factor. Only a small percentage of leukoplakia becomes cancerous. And then there's a version of this called oral hairy leukoplakia, or OHL, and that is typically found in patients with HIV. Erythroplakia, on the other hand, is red, velvety, and these are lesions on the mucosal surface of the oropharynx. You can see them on the floor of the mouth, the palate, the mandibular mucosa, and the tongue. And erythroplakia is considered precancerous. The earliest sign of oral cancer is erythroplakia, the red, raised, kind of eroded area. If a lesion does not heal within 2 weeks or a lump or thickening occurs in the oral cavity, then that should be evaluated for cancer. Again, people should be screened by a dentist 2 times a year. And risks for developing oral cancer include tobacco and alcohol use, poor dentition, or anything that causes, trauma to the oral cavity, chemical exposures at work, poor oral hygiene, and HPV-16. So there's like hundreds of strains of HPV. Some are high risk for cancer, some are low risk and cause warts. HPV-16 is the strain that specifically tends to target the oral mucosa and cause oral cancers. So some key features or key findings of oral cancers are bleeding from the mouth, poor appetite, difficulty chewing, difficulty swallowing, poor nutritional status and weight loss, thick or absent saliva, painless oral lesion that is red, raised, or eroded, and thickening or a lump in the cheek. 90% of oral cancers are squamous cell carcinomas. As you can see here, we can get basal cell carcinomas, but those occur primarily on the lips due to sun exposure. Kaposi sarcoma forms in blood vessels in people who have HIV that has progressed to AIDS, and it can be found in the mouth, the hard palate, the gums, the tongue, and the tonsils, as well as all over the body. Oral cancer management includes radiation, chemotherapy, and surgery. Because the oropharynx has the risk of occluding the airway, maintaining a patent airway truly is our highest priority in these patients, and they need to be on aspiration precautions. At all times, you should keep them in high Fowlers, so upright if you can, and always assess for the gag reflex prior to feeding or drinking. If they're receiving implantation of radioactive substances, they need to be placed on radiation transmission precautions. So special gloves, the double flushing, limitation of visitors, limitation of time in the room. Other concerns include things like infection, bleeding, nutrition status, hydration status, protecting the incision site after surgery, and communication, especially if the larynx was involved. So if they cut out the vocal cords, the patient may have a difficult time communicating after surgery. We want to talk to them about management at home and how to best take care of themselves once they are discharged. So they need to follow their treatment plan for cancer therapies. Taste sensation may be decreased, so they need to add non-spicy seasonings to food to better enjoy it. They should use a thickening agent for liquids if dysphagia is present so that they don't aspirate, and eat soft foods if stomatitis occurs. Inspect the mouth every day for changes such as redness or lesions. Continue meticulous oral hygiene at home using a chemo brush and frequent rinsing. Clean the brush after every use. Use saliva substitute as prescribed, and avoid sun or tanning bed exposure if radiation is part of the therapy. because that will further irritate the skin. Clean with a gentle, non-deodorant soap, such as ivory. And you'll probably recall from, oncology stuff, but radiation tends to cause extreme fatigue because it suppresses the bone marrow. It can cause some skin sensitivity or irritation, but it doesn't cause skin burns. The primary side effect of that really is extreme fatigue. All right, so moving on then to our gastric issues, starting with GERD or gastroesophageal reflux. This is dyspepsia, which is also referred to as heartburn or indigestion. And oftentimes people will complain of things like nighttime coughing, adult onset asthma, hoarseness, pneumonia, and chest discomfort. So those are all possible and common things that we see with GERD. Indigestion is further defined then as abdominal discomfort, feeling uncomfortably full, experiencing nausea and belching, and the symptoms often increase with bending at the waist or lying flat, or if they eat too much food. The most common upper GI disorder in the United States is GERD. And so what happens is the contents of both the stomach and the duodenum, so past the pylorus, are refluxed, so they move backwards into the esophagus, leading to reflux esophagitis, or irritation and inflammation of the esophagus. And so this is usually caused by opening of the lower esophageal sphincter, or the LES. And so you can kind of see that on these pictures here. So normally there's a nice tight pressure on that lower esophageal sphincter, which is sometimes referred to as the cardiac sphincter. And this sphincter is right where the esophagus passes through the opening in the diaphragm between the esophagus and the abdomen. So the stomach contents, the acid that is supposed to be in the stomach, is coming back up and kind of irritating those mucous membranes. And if you can think about any time that you've ever thrown up and how much that acid from the vomit burned your throat, that's what's constantly happening in your esophagus, your lower esophagus, when you have reflux. So this results in inflammation and erosion and ulceration of that tissue in the esophagus. And chronic reflux results in the creation of what we refer to as Barrett's epithelium, which are abnormal endothelial cells. And these cells are more acid resistant, so they're a different type of cell, and they're more tolerant of the acid, so they kind of protect from ulceration and bleeding, but they're more likely to develop cancer. So if you hear somebody talk about Barrett's esophagus or Barrett's esophagitis, so Barrett's esophagus is an esophagus that has had recurrent reflux that has now been replaced by these Barrett's cells. Esophageal stricture can also occur from the damage that occurs as part of the healing process. So we know that scar tissue contracts as it heals. So as the esophagus is healing, it can contract and it can create significant strictures in the esophagus. Smoking cessation and avoiding alcohol use are important to alleviate the symptoms. The factors that contribute to a decreased lower esophageal sphincter pressure, so that decrease the tone or the ability of that lower esophageal sphincter to stay closed, would be consuming caffeinated beverages, things with caffeine in them like chocolate, Things that are highly acidic, like citrus fruits, tomatoes, tomato products, vinegars. Smoking and the use of other tobacco products, as well as alcohol. Calcium channel blockers and anticholinergic drugs, as well as estrogen and progesterone. Nitrates and peppermint and spearmint also relax those sphincters. And then NG tube placement, and it seems strange to have to say that, but if I put a tube in somebody's nose and then pass it down through their esophagus into their stomach, it holds that sphincter open and allows for reflux. Kind of like if you intubate somebody and put a tube into their trachea, it allows for then saliva and secretions to kind of trickle in and cause, VAPS, the ventilator-associated pneumonias. So what do we encourage people to do when they have GERD? So dietary modification is huge. We want them to eat 4 to 6 small meals a day, limit or eliminate fatty foods, fried foods, coffee, tea, cola, chocolate, anything carbonated or caffeinated. Reduce or eliminate spicy foods, acidic foods, alcohol, and tobacco. When I was working in primary care, we used to say no vinegars, tomato products, citrus juices, alcohol or tobacco for at least 6 weeks. And that actually was fairly effective. Don't snack in the evening. Do not eat for at least 2 to 3 hours before you go to bed to allow your stomach really to empty before you lay down. Eat slowly and chew your food thoroughly to reduce belching. Remain upright for at least 1 to 2 hours after meals. Elevate the head of your bed 6 to 12 inches using wooden blocks, or elevate your head using a foam wedge. So never sleep flat in the bed. And you can do this by putting, they say wooden blocks, but even just books. People have used books before. But you want to elevate the actual bed itself, not just like the mattress, or use a wedge or some sort of special pillow to elevate the head. Or if you have one of those sleep number beds, you can elevate the head of your bed that way. Do not wear constrictive clothing, maintain a healthy weight, avoid heavy lifting, straining, or working in a bent over position. And it says chew chewable antacids thoroughly and follow with a glass of water. So good advice if you're going to use chewable antacids. So other medications aside from antacids. Antacids are available over the counter. Those are good for short-term use. Things like calcium, magnesium, and aluminum-based antacids are helpful at neutralizing stomach acid. Gaviscon also can be used, and that creates a foam that, in theory, kind of like coats the gastric contents. So you want to take that like right after you eat, kind of with food. And that way, if you reflux, it's supposed to kind of coat the reflux and prevent it from irritating the esophagus. Some people actually mix sodium bicarbonate with water and drink that. So oral bicarbonate, remember, is a base. So sodium bicarbonate is a base it's an alkaline, so it will neutralize that gastric acid. But any of these things, any of the antacids taken in excess can cause metabolic alkalosis. So we just need to be careful of how much you take. Histamine receptor antagonists, also referred to as H2 receptor antagonists or H2 blockers, are also available over the counter. These are drugs like famotidine, which is Pepcid, cimetidine, which is Tagamet, and ranitidine, which is Zantac. These are longer acting and they decrease gastric acid secretion and therefore can promote healing. Proton pump inhibitors, some are available over the counter and some only by prescription. These include things like omeprazole, which is Prilosec, rabeprazole, which is Acefex, pantoprazole, which is Protonix, lansoprazole, which is Prevacid, and esomeprazole, which is Nexium. These are long-acting and can be used long-term. They decrease gastric acid secretion, but their use is associated with hip fractures, community-acquired pneumonia, and C. diff infections, because our body really is dependent upon an acidic state in our stomach as well as our entire GI tract to protect us from infection. So if we can manage people with dietary changes and lifestyle modification, that's much better than having to put somebody on an H2 blocker or a PPI long term. So hiatal hernias and GERD kind of go hand in hand. Hiatal hernias are also referred to as diaphragmatic hernias because there's a protrusion of the stomach up through the esophageal hiatus of the diaphragm into the chest. So that's the same location where I was just saying where the lower esophageal sphincter is, where it kind of connects the esophagus into the stomach. There's two types. There's a sliding hiatal hernia where the lower esophageal sphincter actually slides up and down and crosses into the chest wall. And then there's this rolling hiatal hernia where the fundus, or kind of like the top pouch of the stomach, actually rolls, it calls, up into, and the lower esophageal sphincter stays where it is. So the stomach itself doesn't move, just kind of the fundus or the top part rolls up and creates this paraesophageal hiatal hernia. So the symptoms of hiatal hernias are similar to GERD, but also include chest discomfort. So again, anytime you have chest pain, anything between the navel and the nose, you should get an EKG to make sure that it's not cardiac. And honestly, for both GERD and hiatal hernias, that's what drives people a lot of times to come into the hospital or to be seen, is that they're developing upper epigastric or chest discomfort with eating. We can diagnose a hiatal hernia by doing a barium swallow, and you can see with the barium that there's either that outpouching with the sliding hiatal hernia, or there's that kind of extra little pouch with the rolling hiatal hernia. Conservative management includes things like diet and lifestyle modification, and patient teaching is critical. So again, small meals, avoid triggers, head of the bed elevated at least 6 inches to sleep, remain upright for 2 hours after eating, avoid straining, and clothing that's tight around the waist. We can do surgery. So surgery includes either laparoscopic or transthoracic, so fully open fundoplication, and this is called Nielsen's fundoplication, and where the fundus of the stomach is wrapped around the top of the stomach in order to create kind of a thicker top so that it can't slide up and down, so it doesn't fit through there anymore. So if the person has a laparoscopic surgery, they may not have an NG tube, but if they have a transthoracic surgery, they probably will have an NG tube. So after their surgery, it would be important for you to manage the NG tube. Don't flush it or reposition it after surgery, because you can damage the suture lines. It's normal for an NG tube when you've just had surgery on your stomach to have some blood in it at first, so it could be bloody or it could be like a darker brown, like old blood at first, but usually by the first day post-op, the end of the first day post-op, it has returned to that normal green color. You should still check placement every 4 to 8 hours and make sure that it's anchored really well so it doesn't slide around. And then, monitor to make sure that it doesn't get plugged up, because if it gets obstructed and it can't drain, the person could have gastric distension, which would put pressure on the sutures, and then they could end up vomiting. Also with the transthoracic, they're going to have like chest tubes and JP drains and things like that. So they're going to be a more complicated medical patient. If they have laparoscopic surgery, though, oftentimes they, get to go home fairly quickly. Sometimes it's an overnight stay and sometimes it's same-day surgery. Discharge instructions should include to stay on a soft diet for about a week. So things like mashed potatoes, puddings, custard, milkshakes. Avoid anything carbonated, tough foods, raw vegetables, anything that's going to be gas producing as well. Avoid that. Remain on anti-reflux medications as prescribed for at least a month. Do not drive for a week after surgery, and do not drive if taking opioid pain medications. Walk every day, but do not do any heavy lifting. Remove the dressings about 2 days after surgery and shower, but allow the steri strips to kind of fall off on their own. And it's okay if people want to trim the edges of steri strips, like if the edges start to peel up and they're bothering them, they can trim the edges, but we like steri strips to fall off on their own to really give that skin time to heal and create that scar. Wash incisions with soap and water, rinse well, pat dry, and then monitor for signs and symptoms of infection. So they should report redness, pain, discharge, fever, anything like that to their surgeon, and then follow up as directed. Esophageal tumors or esophageal cancer is the cancer then that we would see in the esophagus. So we talked about oral cancer, so now moving downwards. Signs and symptoms include dysphagia from narrowing of the esophagus, weight loss, painful swallowing, regurgitation, vomiting, halitosis, so bad breath, and hiccups. If it's near the vocal cords, they can also have hoarse voice. So persistent and progressive dysphagia is the most common feature, and oftentimes they'll also get a feeling of food getting stuck in their throat. So a lot of times they'll come in complaining of, again, chest pain, throat pain, something else, not really thinking that it's esophageal. Most of these tumors are malignant and they grow very rapidly. They can spread to the lymph nodes and metastasize easily. The risks of developing esophageal cancer include consuming smoked or pickled foods, alcohol abuse, recurrent or uncontrolled GERD, smoking, obesity, Barrett's esophagus, and malnutrition, believe it or not. Nitrosamines. So nitrosamines are a kind of side effect of high heat or rapid heat applied to nitrates. So like sodium nitrate that is used in foods as a preservative changes chemical form when it's heated too rapidly or too high heat and becomes a carcinogen. And then pickled and fermented foods, as I said, and smoked foods all are known carcinogens. This is diagnosed with a barium swallow for the cause of dysphagia, and then they'll notice that there's a lump or a tumor, and then they do an ultrasound guided fine needle aspiration biopsy to confirm that it's cancerous and to type the cancer. Because esophageal tumors are below the level of vocal cords, the airway should be patent and that shouldn't be an issue, but the primary concern then is weight loss related to difficulty eating. Treatment includes chemotherapy, radiation, and surgery. Dietary and food modifications.
I found this on the web.
Soft foods and thickened liquids. Enteral tube feedings temporarily are sometimes required. And then there's what's called photodynamic therapy, where they can inject a chemical called photofrin, which collects in the cancerous tumor. And then 2 days later, they endoscopically apply light to the area, and it destroys the cancer cells. So that can be used for palliatively to shrink a tumor or curatively for very small tumors. When somebody uses the photodynamic therapy, they have to avoid sunlight exposure for at least 1 to 3 months afterwards, including like sunglasses, hats, and long sleeve clothing. And then we can also do esophageal dilation for strictures. Surgery is called an esophagectomy, which is a removal of all or part of the esophagus. And there's an esophagogastrostomy, where part of the esophagus and the proximal stomach are removed. The colon interposition can be performed, and that's where the colon is used in place of the esophagus. So there's a picture of that here. Post-operatively, airway is the primary concern. They might be intubated for the first 24 hours, so they're going to wake up kind of confused, scared, in pain, not being able to communicate. So make sure that you keep that in mind. You want to keep the head elevated, so keep them somewhere between semi-Fowlers and high Fowlers, so 30 to 90 degrees. And if they had a lymph node resection, they're at increased risk of fluid volume overload. They have had a history of poor nutrition. Remember, that's why they're here. They couldn't eat. So they're already starting at an increased risk of infection. And they have an increased risk of developing what's called mediastinus, which is an inflammation or infection in the mediastinum. And look for fever, fluid accumulation, so like crackles in the lungs, and signs and symptoms of shock, because this can be fatal. Call the surgeon for any signs and symptoms of infection and a rapid response team for any signs and symptoms of shock after any of these surgeries. Do not irrigate or reposition the NG tube without a physician order. Once the person is able to start taking oral intake, so PO is resumed, eat 6 to 8 small meals a day, and fluids should be between, not with, food. Esophageal trauma can also occur that might require surgery or repair, and these can be blunt injuries, chemical burns. It can actually occur as a side effect of surgery or endoscopy, but that is rare, and it can occur with forceful continued vomiting, and that's called a Mallory-Weiss tear. This can lead to esophageal perforation. Our primary concern in these cases is airway patency, breathing, to monitor and diagnose the cause of chest pain, to make sure that they can swallow okay, to control vomiting, and to control any bleeding. So in general, with these patients, we want to teach the patient and the family about safety, nutrition, and infection prevention and signs and symptoms. Teach about the management of esophageal diseases like controlling the GERD, smoking cessation, avoiding alcohol, and monitoring weight. And if dysphagia is present, remain with the patient during feeding. That's really critical. Teach about any specific procedures or medications that you're going to utilize that they may not be familiar with. Moving on a little bit further down, we're going to talk about the stomach and gastritis and gastric ulcers. So gastritis is inflammation of the gastric mucosa that can result in irritation and or ulceration, and then that can lead to bleeding. And you see here, again, just a picture of the stomach, but the fundus is kind of that upper part that's where I was talking about the Nielsen's fundoplication, that they can actually wrap around kind of the cardia, the top of the stomach, and that's where it's sometimes called the lower esophageal sphincter, sometimes called that cardiac sphincter. So when we get, let me just click on my little drawer here for a second. When we get gastritis, it's typically in this area where the fundus is, Gastric cancer oftentimes is kind of over here. This is a gastric ulcer that's up here. And remember that the stomach itself is very acidic, right? And then this is a duodenal ulcer, and a duodenal ulcer is below the level of the pyloric sphincter. And the duodenum is typically less acidic. The acid has broken down, the fats and the proteins, and has turned, kind of everything has been churned and has turned to chyme. And as it is that kind of thick paste and emptying into the duodenum is also getting the alkaline secretions from the pancreas and the gallbladder, like the bile salts, that kind of neutralize all those acids. So the duodenum is not well protected against acids. So keep that in mind when we're thinking about the difference between the gastric ulcers and duodenal ulcers and kind of the stomach in general here. All right, I digress. So acute gastritis is, again, inflammation of the gastric mucosa or submucosa after exposure to local irritants. This typically has rapid onset of epigastric pain and discomfort, nausea or vomiting. The person may vomit blood, which is called hematemesis. They also might have gastric hemorrhage, so you might get some melena stool, and then dyspepsia or heartburn and anorexia. We see this most commonly with things that can enhance or cause bleeding, like aspirin, NSAIDs, alcohol, caffeine, steroids, among other irritants and medications. Infection with E. coli, salmonella, staph, strep, and these also can be stress-induced. Chronic gastritis, on the other hand, is a vague report of epigastric pain that's relieved by food, anorexia, nausea or vomiting, intolerance of fatty and spicy foods, and you may notice pernicious anemia because this autoimmune type destroys the parietal cells and the intrinsic factor. So we're unable to absorb vitamin B12, and so we develop pernicious anemia, and then they get that glossitis, the beefy red tongue, and they can get the paresthesias, the tingling in the hands. An H. pylori infection, though, is the #1 cause of chronic gastritis. So this is Helicobacter pylori, and it's in the helical shape, which is why it got its name. And basically, it's able to kind of attach to and attack the walls of the stomach, and it changes the way that urea is broken down. It kind of changes the acid-base balance, and then it causes a breakdown in the lining or the protection and then the lining of the stomach, so it leads to ulcers. In older adults, we can get atrophic gastritis, which is one of our leading causes of gastric cancer. So we have a chronic type A and a chronic type B of gastric cancer, and chronic type A is the antibodies, the non-erosive, and chronic type B is the H. pylori, alcohol, smoking. So again, acute gastritis, epigastric pain, and discomfort, and these people really complain of pain, and it's kind of a rapid onset, and this is relieved with antacids oftentimes, and then chronic gastritis is more vague, and it's relieved more by food. So the treatment depends on the diagnosis. So the first thing that we want to do is look for a diagnosis. We diagnose the Helicobacter pylori with either blood, stool, or a breath test. So there's a blood test for antibodies. There's a stool test that can check for Helicobacter pylori as well. And then there is the urea breath test that just checks for the presence of urea. And the stool checks for the antigen. If that is the case, then we treat with what's called the triple therapy, which is the gold standard. They can also do an EGD, which is the upper endoscopy down into the stomach, to take samples and kind of look around, look at ulcerations, and to test for H. pylori. So the histamine receptor antagonists, proton pump inhibitors are kind of a common treatment for gastritis. When H. pylori is present, we move then to a PPI plus 2 antibiotics. And so typically we do either Flagyl and tetracycline or clarithromycin and amoxicillin combined together for 10 to 14 days. You can also add in Pepto-Bismol. That helps kind of coat the stomach, and bismuth also is kind of an antimicrobial, and that will help also. Antacids help to decrease the overall acid content, and then sucralfate will kind of coat the stomach and stops the acid from reaching the ulcers to allow them to start to heal. Conservative management, though, is also important when dealing with gastritis. So diet, stress, and lifestyle modifications are important. Avoiding the irritants is probably the most critical thing. So avoiding caffeine, alcohol, NSAIDs, tomato products, acids, spicy foods, tobacco, whatever it is that triggers their upset stomach, they should be avoiding. And then if the person does have pernicious anemia, replacing vitamin B12 is going to be important as well. So peptic ulcer disease, we can get the gastric ulcers, there's duodenal ulcers, and then there's also stress ulcers. And with the gastric ulcers, these have intermittent pain in the high left epigastric or kind of upper abdominal area, typically worse 1 to 2 hours after eating, and not relieved by antacids. And because the blood is right in the stomach itself, coffee ground emesis or even bright red blood is more common. Duodenal ulcers are below the level of the stomach in the duodenum, so the pain is more intermittent, mid-epigastric or upper abdominal, and it actually is relieved by eating and then gets worse about 2 to 4 hours after eating, like once the stomach is empty and the acids start to get in there again without the food. So this is relieved by antacids, and it's more common to have melena stools or blood in the stool because the blood is already below the level of the stomach, and so it just passes in the gastrointestinal tract. Again, ulcers are most commonly caused by H. pylori and NSAID use. They can cause hemorrhage, perforation, pyloric obstruction, and intractable ulcer disease. So if they're not treated early on, the person, or if, whatever, they're not treated well, or if the condition persists, the person can develop ulcers that they just can't heal. We would do the same labs to look for H. pylori, so blood, urea breath test, or stool antigen testing. and an EGD can also be done for H. pylori and biopsy testing for peptic ulcer disease. The triple therapy, so the proton pump inhibitor and 2 antibiotics, is still the treatment of choice. And then diet and lifestyle modifications, as for gastritis, would also be used to to treat peptic ulcer disease. So you want to monitor these patients for sharp, sudden, persistent pain, severe epigastric or abdominal pain, bloody or black stools, blood in the vomit, and coffee ground emesis that would indicate some sort of a gastric hemorrhage. And then monitor for signs and symptoms of perforation. So perforation would be sudden, sharp pain in the mid-epigastric region that spreads over the entire abdomen with a rigid, board-like stiffness on exam. Patients oftentimes will present in the fetal position, and when this happens, when you get a perforation and this causes peritonitis, you're going to get peristalsis that diminishes and development of a paralytic ileus. And very quickly, because this is the GI tract, you can develop bacterial septicemia, which has a really high mortality rate. So look for, again, evidence of bleeding or perforation. Do a lot of good patient education and talk about the importance of medication adherence or compliance. Manage their pain and monitor for complications of bleeding and perforation. So gastric bleeding puts us at risk for hypovolemic shock. NPO, protect the airway, IV hydration, oxygen, NG tube, and ligation of the bleeds. So typically we would do 2 large bore IV lines, monitor vitals closely, monitor the H&H and the oxygen saturation. If you do have to do gastric lavage, we don't use ice water for that anymore. You just use either normal saline or room temperature water. It doesn't matter if it's sterile water or tap water. Basically what you're doing is just flushing the blood out of the stomach to stop the irritation. We used to use ice water in the NG tube thinking that it would clamp down the blood vessels, but we know that making the person hypothermic by putting cold water into a large organ like the intestines actually can impair clotting. So we don't want to do ice water lavage. The same safety rules apply if the person has an EGD to locate and cauterize the bleed. So that would be NPO until gag returns, monitor for bleeding, and prevent aspiration. And you can get cancer in your stomach as well. So gastric cancer is more prevalent in an alkaline environment like atrophic gastritis or people who take PPIs long term, because these allow for bacterial growth like H. pylori, which results in mucosa-associated lymphoid tissue or MALT lymphomas. And these metastasize readily, and the mortality rate is high because it's asymptomatic until it's metastatic. The risks for developing gastric cancer or MALT lymphomas include H. pylori infections, pernicious anemia, gastric polyps, and chronic atrophic gastritis, as well as a condition called achlorhydria, which is where people do not produce hydrochloric acid. Early on, people will experience indigestion, abdominal discomfort that's initially resolved with antacids, early satiety where they have this feeling of fullness, and epigastric back or retrosternal pain. Not something that people would necessarily seek emergency medicine for or even go to their doctor for if they could treat it with over-the-counter antacids. Advanced gastric cancer, though, has nausea and vomiting, symptoms of an obstruction, iron deficiency anemia, palpable epigastric masses, enlarged lymph nodes, weakness and fatigue, and progressive weight loss. And again, typically people have metastatic disease before they tend to seek care. Eating pickled foods and nitrates from processed foods and excess salt, we know, increases your risk of developing gastric cancer, just like esophageal cancer. Diagnosis is by biopsy with an EGD, and treatment includes chemotherapy, radiation, and surgery. So surgery is called a, well, there's two types. There's a subtotal or partial gastrectomy for tumors that are in the mid to lower part of the stomach, and that just removes that part of the stomach, just the lower part. And then there's a total gastrectomy with anastomosis of the esophagus for upper tumors. In this picture, this is the Bill Roth one where the distal stomach is removed. And then there's a Bill Roth 2 where more of the distal stomach is removed. So this is kind of that subtotal gastrectomy. A total gastrectomy occurs when you take out the entire stomach. So in this case, the entire stomach is removed, and then the esophagus is connected directly to the jejunum or the duodenum, and this results obviously then in some malabsorption issues. The biggest thing that we worry about with these type of surgeries is something, in addition to malabsorption, is something called dumping syndrome. So there's two types. There's early dumping syndrome that occurs 30 minutes after eating, and this is due to rapid transit of food into the small intestine. And so you can see here that it just moves from the esophagus, and if they create like a little pouch, if you have fluid with your meal, it just flushes it right into the small intestine, and then all of this water gets sucked in there. So the food then shifts fluid into the gut, and that causes abdominal distension. And when you do that, it kind of triggers this vagal response. So the person gets like vertigo, tachycardia, syncope, sweating, pallor, palpitations, fatigue, and then the body thinks it needs to have like this emergent bowel movement, and they get this rapid kind of explosive diarrhea oftentimes. Late dumping syndrome can occur 90 minutes to 3 hours after eating as a response to spikes in insulin levels, and those people tend to get a later onset, but dizziness, lightheadedness, palpitations, sweating, and confusion. To help prevent dumping syndrome, avoid fluids with meals, avoid high carb foods as well. And remember that because the stomach is responsible for the absorption of extrinsic factor, which is B12, by intrinsic factor, which is made in the stomach, that people who've had their stomach removed, or even part of their stomach removed, and this goes for even all weight loss surgeries, that they're going to need vitamin B12 replacement. So they will probably develop glossitis, that smooth, shiny, beefy red tongue, and other signs and symptoms of B12 deficiency. So in general, you want to identify patients at risk for gastritis and peptic ulcer disease, so H. pylori, NSAID use, smoking, alcohol. Teach adults to prevent peptic ulcer disease by avoiding excess caffeine, alcohol, coffee, aspirin, NSAIDs, and tobacco. If diagnosed with H. pylori, strict adherence to the treatment plan is essential to prevent gastric cancer. So remember that the H. pylori causes the reflux and the gastritis, which and the peptic ulcer disease, and all of that leads to cellular changes that then lead to cancer. Gastric problems lead to malnourishment, so watch for life-threatening complications such as hemorrhage and perforation as well. And after an EGD, monitor vital signs, heart rhythm, and oxygen saturation. To prevent aspiration, assess the gag reflex and ensure that it's intact before giving the patient food or drink. Observe signs and symptoms of dumping syndrome after gastric surgery. and control pain. Early ambulation helps keep things moving the way that it should. Checking the belly often is important. Providing lots of education is important as well. So these are the big complications that we're always monitoring for: hemorrhaging, dumping syndrome, steatorrhea, which is fatty stools from malabsorption syndromes, gastric distension, nutritional problems, and pyloric obstruction, so swelling or problems with the pylorus and things can't exit the stomach. All right, that was an hour of your time. Thank you for watching, and good luck. Let me know if I can help at all.